All right. The subject of the day is psychotherapy in medication-assisted treatment. And Thank you, Echo, for sponsoring this talk. Many people have used medication-assisted treatment as a concept for the treatment of opiate use disorder and alcohol use disorder. I think it would be more beneficial to define this as medication treatment of opiate use disorder. So medication first, uh, and then when the brain is a little more stable, it's a lot easier to talk to. So patient education regarding what the medicine is, how it works, how to use it, definitely enhances patient retention. Now, once you have stabilized a person with induction onto something such as buprenorphine or Suboxone, many patients will benefit from psychotherapy. A lot of psychotherapy can be delivered in the primary care setting, and sometimes you'll want to reach out to a mental health professional. So this brings up a number of questions. Well, what is psychotherapy? How does it work? What is the mechanism of action? What types can be provided in the primary care setting? And when should we refer to a psychotherapist? Psyche, uh, we don't have in our language good noise, but we can think of it as cough, ka, ki, chi. Basically, it means bubble. So psyche implies mind, which is composed of all of the ideas that we can link together. Everything that we can put together is that bubble of our mind, all of the things that we can reach towards. And of course, spiros, breath, is a sphere, a bubble. So now, what is therapeutic? Thera is old, Putan is apprentice or son, and tic is technique. So therapeutic is the application of an established technique. So psychotherapy involves learning. So we use techniques to produce improved function in cognitions and in self-talk. We hope to influence habits, attitudes, and changes in behavior. And we hope that our patient will be able to have some arousal regulation. Now, by arousal, we're talking about how anxious, how angry they are, and also sometimes uh, um, instead of calming people down, we want to wake them up. So we also want to provide activities to increase their activation and energy so that they can engage socially and accomplish their activities of daily living. So learning occurs by the change in the number and location of synapses. Basically, when something occurs, short-term memory loops are triggered into action, and then the nerve cells adapt to that pattern of activity by changing the number and location of synapses. So learning can occur from experiences and from adaptation to substance use. So learning gives us the ability to recognize things and to put things together. And so we can develop then these perceptions and perceptual projection. So in perceptual projection, we are able to then see what is likely to happen in the future. And because these short-term memory loops persist, we can scan our attention forward and back into the past. And of course, being here now in the present moment is sometimes more fun. So most of these sensations and perceptions fade away and become memories. But some sources of action, or some sources of activation, which could be sensations or sources in the brainstem, increase in intensity and can create longer and longer trains of thought. And this can result in desires. So desires result in ideas and plans. The sensation attached to an ideal forms of desire, and then memories and beliefs are assembled into a little movie about how to accomplish that desire. So we also have this vagus nerve. Now, the vagus nerve wanders down and gets into a lot of things, and it's active in anticipation and emotion. So when we are considering an idea, frequently then it can trigger activity in the vagus nerve, resulting in this loop of activity that we describe as an emotion. So down at the bottom here, you can see the sensations and perceptions. Then on the left upper, we can see the formation of desires and ideas. We consider the idea. We might decide to get ready. The internal tension occurs, and then that in turn alters our sensations and results in this loop of activity we experience as emotions. So because we have lots of things going on at the same time, and we have this ability to take shortcuts and to learn things out of habit. So this striatum or septum, some people call it the basal ganglia, this is where habit lives. And this is also where trauma and addictions and many other learned behaviors, deeply learned behaviors reside. So the brain has a shortcut to get things done and to free the attention to think about other things. And this is the habit loop. And so sometimes people develop attitudes which consist of beliefs and assumptions that have been layered over by other experiences they are no longer aware of. So we can intervene in this process of emotion by teaching people to edit, to be aware of and edit their cognitions and self-talk. This is how cognitive behavioral therapy works. And we can help them with that modulation of arousal. And this is where mindfulness, smooth breathing, meditation is often very helpful. So we've got several types of psychotherapy that can be applied in the primary care setting. We've got motivational interviewing, which consists of a type of reflective listening, and we can elicit the patient's goals and strategies. We can also do cognitive behavioral therapy and mindfulness training. So not everything can be addressed in your primary care office, and many times you'll want to refer to a psychotherapist. And that can be the case in sexual trauma, personality disorders, psychosis, and ongoing dysfunction despite your efforts. So one thing that is very helpful, in addition to teaching people how to use the medications and how the medications work, is therapeutic neuroscience education. Studies have demonstrated that all of the substances of abuse trigger the release of dopamine, and with repetition, less and less dopamine is released. And way back in 1973, Dr. Solomon came up with the opponent process model based on these measurements. And then in 2009, Dr. Meisel's gave a good article suggesting that it is dynorphin that is the opponent process that suppresses dopamine release. And making patients aware of this often helps them to avoid lapsing back to substance use. So motivational interviewing, we have several stages. Pre-contemplation, where we provide information, contemplation, preparation, action, maintenance. So we help them explore, we help them to understand what's going on, and we can get them to reflect to us what they understand about things and explore strategies. Many of us are familiar with motivational interviewing techniques. We can also use cognitive behavioral therapy, which in this upper left of the circle here, you can see cognitions and self-talk. And yes, in our thoughts, we do talk to ourselves. And we can develop techniques to journal and analyze these internal scripts. For example, guy's going out to go to work and his car wouldn't start. So there he goes with his inner rant, piece of crud car, come on, darn it, arg. I might as well go live under a bridge. So we can then edit that into a more effective and less inflammatory uh, stream of thoughts and ideas and be less upset. We can also teach people mindfulness techniques to calm down that inner tension or to raise the inner energies so that they can get things done. One thing I found useful is the suffocation alarm hypothesis of panic disorder. Basically, the accumulation of carbon dioxide triggers the suffocation alarm and adrenaline release. And by redefining, by reframing what's going on in a panic attack, oftentimes you can teach people to hit the snooze button and cause these episodes to subside. And so, medication is the primary treatment of opiate use disorder. It's not medication-assisted treatment. Medication is treatment. And to withhold that is to expose your patient to increased risk of overdose and death. So we can facilitate psychotherapy, therapeutic neuroscience education, and education about medications and how they work to enhance retention and treatment. If the patient continues to struggle, has a personality disorder, severe PTSD, or sexual trauma, then you might want to refer them to a psychotherapist, a mental health professional. So basically, in addiction, what we are dealing with is an out of balance brain. You can see in this picture A, we've got this large red triangle, the prefrontal cortex, and normally that's what's in charge. That's where we make our plans. That's where we store our ideas about who we are and what we're going to do. We could call this picture B, the disinhibited brain. And you can see that the prefrontal cortex in the upper right of the diagram B has shrunk in size because its activity is suppressed by the activation in the brainstem. And so what we are wanting to do to improve function is to help people stay in themselves, to retain access to their plans and ideas and be able to carry them out. So yeah, that's psychotherapy with medication treatment for opiate use disorder. Any questions?
And one thing that I might ask, given sort of my roots in family medicine, is, if you'd have sort of pearls around, integrating some of this into, a primary care practice where you're following up with someone who might be on medication for a use disorder, and would there be sort of some key strategies in what might be, the context of briefer visits than say your usual psychotherapy kind of sessions that might be helpful for folks?
So yeah, definitely. So the reflective listening and in taking a history and motivational interviewing fit like a hand in a glove. And it's a real easy, convenient strategy to employ to get your patient to think about where they are and where they're going to go. And also, in the course of the patient emoting in front of you when they're sharing their feelings, oftentimes the language that they use will be full of catastrophic and inflammatory terms and cuss words. And you can reflect back to them edited versions of that are less inflammatory and more helpful. The other thing I found useful is the smooth breathing techniques to help reduce the frequency, duration, and intensity of panic episodes. These techniques are actually easy to apply. I started doing CBT with my new onset diabetics, and it's very interesting to see that a lot of times eating patterns are part of a person's emotional regulation strategy. So when you give them alternatives, yeah, they can definitely change their lifestyle. And so these things are applicable to a wide variety of situations besides substance use disorders. And practice, practice, practice. So one thing that I do in getting to know the patient, I try to take a good history, Then I try to educate them at that visit about how the medications work. And then I start a process of monitoring the effects and the process of education. And I first try to reframe their map of substance use and whether or not it's going to bring them long-term happiness. And then I teach them gradually skills involving cognitive behavioral therapy. And then once you accomplish that, I call it a front-loading process, where your initial visits, maybe the first 4 to 6 visits, will be a little bit longer than most of your office
Mhm.
visits. But then after that, you can reinforce these ideas during a pretty short office visit. And it's actually a lot of fun to watch people apply these techniques and change and grow.
Yeah, that's great. Really appreciate that. And yeah, we may just in those settings want to have an eye to that more frequent contact early on, or and to provide some of that education. But are there also resources, John, that you point patients to for supporting that practice in terms of literature or online resources?
Yes, yes, there are online resources that I use. Um, One of the sources that I use is at a website called spiritlakewellness.org, and you can go under publications. Uh, One source of education about opiates is The Peril and Folly of Opiate Abuse. And then a nice source of information for patients about cognitive behavioral therapy is in the cognitive change process. And those documents, you can download them and print them out for your patients. It's often helpful, but I've found that uh, many patients may intend to read something, but then never get to it. So if I go through it with them, it's more effective.
Thanks for that, John. We did have a question come up in the chat from Katie Myjal. Hello, Katie. Wondering about something kind of akin to treatment matching, right? Like if you have a decision process around what type of psychotherapy you might start with, or something that you try first, or these sort of tools in a toolkit that you kind of apply fairly broadly across patients.
So yeah, I think one of the challenges is to prepare the mind that you're dealing with to get it into a relatively calm state and ready to learn. So if the patient is particularly inflammatory, uh, for example, with PTSD, um, sometimes mindfulness techniques can get them to achieve a calm enough state to where they can actually listen to you. Some people have estimated that we spend roughly half of our day inside our own head running simulations. So when you're talking to your patient and you're having an office visit, yeah, sometimes they're having simulations go on in their head. A good example of this is when you tell somebody that they have cancer. Uh, Oftentimes they don't remember the rest of the visit. They're off in their own world. So you got to get people out of their world. And mindfulness, smooth breathing is a way to do that. And then sometimes you have to refer to a psychotherapist for something like EMDR to address the trauma before you can get them calm enough to actually stay in the room with you. So yeah, basically, I look at what's going to calm them down so that we can communicate and start to share information. It's kind of a harsh topic to cover in 15 minutes. There's over 1,000 types of psychotherapy. And one of my friends determined that the most effective aspect of psychotherapy is the relationship. And that relationship is a give and take of information. Just by listening to the patient's story, they hear themselves as well. They not only see it reflected in how you respond to their story, but they also see themselves. And sometimes uh, that in and of itself is therapeutic.
Yeah, I was attending a conference some time ago where I heard, I think some of what you're alluding to referred to as accurate empathy, and that establishment of that with a client being so important, and that being associated with improvement in outcomes. And so if a client feels like they aren't being accurately empathized with, that their sort of concerns aren't being accurately reflected, that can present a challenge to forward movement with the relationship.
Yeah, that's definitely true. Uh, I think that authentic relationship, uh, uh, certainly, especially at first, in taking a history, listening to their story goes a long way to developing that therapeutic relationship.
Mhm.
And then there's all sorts of things that can develop in therapeutic relationships, transference and countertransference, which, if you can manage it, can be productive. And sometimes we let the mental health professionals uh, uh, help us with that.